a job in a community setting in Havergrave, Maryland, when it all started off. And it was a community. They were opening a new ICU with 6 beds, and were offering me this job to be the ICU director and really start this whole service. So it wasn't exactly what I wanted, because I didn't want to leave academics, I didn't want to leave teaching, but I did want to go north, because again, it just wasn't my cup of tea. So I took the job figuring that I would be there a couple of years and, see how that went, and then move into in my mind, a better situation. The brief story is, did my fellowship here, went to Florida, didn't like Florida, wanted to get out of Florida, took a private practice job in Maryland. So in Maryland, the idea was that I was going to start a critical care service at this community hospital. So as I say, wasn't where I planned to be, wasn't what I planned to do, didn't want to be in a small little hospital, but I will tell you it taught me a lot of things. And so I went from my plan of I'm not staying here for more than 2 years to I was there 11 years. And there were a lot of things that I learned there, and that's what I want to try to share with you. Because the world in which you've trained, Cooper, is not the world that is out there in most hospitals, right? So the way that you're used to doing things here, the way the ICU runs is not reality in most hospitals, right? Because critical care, most of critical care is practiced in small community hospitals. It's not in large tertiary referral centers, right? And those of you who have gone out to the Inspiras or the Cape Mays, you will see some of that. So, okay, now if I can just figure out how to advance.
Click on the slideshow just to keep it going.
Click on the slideshow. Okay. So as you move into ICU administration, you want to make yourself as useful as you can possibly be to the institution. So on this slide, there's a guy wearing a million hats, and the guy says, yeah, very clever, I get it. But that's really what you need to develop when you are an intensivist and you go to a community hospital, or really even here at Cooper, right? You need to be doing something other than just being the doctor, right? When I went to this small place in Maryland, as it ended up 11 years later, I was the chief of pulmonary, I was the head of critical care, I was on the NEC committee, I chaired the P&T committee, I ran respiratory care. That's not because I was so great. It was a small hospital, right? And I was able to control all of the things around me. So if you think of what I said, what I just told you, when I needed a new drug, for instance, at that time Precedex was just coming out. It was very expensive, right? But in my mind, if we could save ICU days by using Precedex, rather than the Versed and the morphine, like the stuff you're using now, right, where you wait a week for them to wake up, this is sort of a throwback to what it used to be like. So I was able to convince the P&T committee that they should, in fact, spend all of this money, and at that time it was a lot of money to run Precedex, right? But I chaired the P&T committee. So, obviously everyone voted the way they wanted to vote, but obviously you have influence, right? The hospital at the time had many different ventilators. They had like one ventilator from every company or something. And so it was very hard to keep respiratory therapists up to date on how do you run all of these ventilators when there were literally, I think we had like 8 different kinds of ventilators. So I got the hospital to buy an entire fleet of ventilators off of a budget cycle. So my point is, when you start work as an intensivist, there are really so many different things that the ICU touches and affects. You want to sort of learn how to put those different hats on, get involved in those different things, so you have some control over them, right? I would honestly tell you, it's much harder to work here at Cooper than it was to work there, because it's a smaller number of people, and again, I have more control, right? So things to think about. Also, the whole situation across the country, and this isn't COVID. These slides are actually pre-COVID, but we're at a point in time when ICUs are at capacity. Now you know that here, right? And that's pretty much true in most places where ICU beds are hard to find. You find that ambulances can potentially be diverted. That costs hospitals millions of dollars. And when elective surgeries are canceled, that costs them millions of dollars, AKA COVID, right? There haven't been any elective surgeries going on. Hospitals losing a lot of money. So there's been a lot of rising rising volumes. It's hard to get current information on this stuff. I mean, I tried to find some new numbers, and again, I think that the number, I couldn't find a current number of ICU beds. I could find this 34.7 ICU beds per capita, but I couldn't actually come up with a number of beds. This almost million beds, I think actually is not ICU beds. I think it's total beds. So again, I couldn't find what the current number was. I thought with the COVID thing I actually would be able to find that, but I can't. Point is, there still aren't enough beds. And simply adding beds is not that easy. So you understand that in the hospital, you have to go back to your state and ask for more beds, right? You can't just build the 10th floor out and say, okay, we got 30 more beds. This hospital will have to apply to the state to actually get permission to open those beds, right? So it's not an automatic, you build it and they will come. You actually have to get state permission. And depending upon where you are and that may be easy, it may not be so easy. But even if you get that, you still have to get nurses, you still have to get respiratory care, you still have to get pharmacists. All of those things are actually, they're not as many people out there looking for those jobs as you think there might be. And then nursing recruitment, it takes about 60 days to get a new nurse. So again, if you're gonna staff up to 10 more beds or staff up for 30 more beds, it takes some time, right? So you can't immediately solve your problem when you need more ICU beds. And then there's the discussion about, actually, if we used all the beds we have correctly, would we need more beds? Now, that's not necessarily a problem for us at Cooper, except maybe we could use the example of the hearts, right? So if we're talking about normal days, when we have the hearts that come out, and they're on their day 2, and they're like perfectly fine, but we have to keep them a day, right? That's holding that ICU bed. So, so in hospitals across the country where there are not necessarily intensivists, you know, the attending will be like, oh, no, let's just keep them for another day. Well, why? Well, 1, that person knows they're well taken care of, right? 2, they're not going to get the phone calls from the floor nurse all night long. And so there is hesitancy to move people out of the ICU in a quick fashion. You're used to simply putting in the order and then eventually they will go, right, when the bed's available. In a system where you're not running all those patients, it doesn't necessarily go that quickly. So then, length of stay, same sort of thing that we've talked about. Apache data shows that about 1/3 of patients have a length of stay that exceeds the predicted value. So that's why, you know, when we round and such, I'm like, let's get this patient on the list. Let's get this patient on the list. Because when you put them on the transfer list, even if they don't move, is when their status changes for, and you have to report numbers to outside agencies, what's your length of stay. So even if they physically still sit there another 2 days, when you put them on the bed list, it actually changes the status, okay? So, again, it's one of the things that we have to keep an eye on. On this, if you look at this chart, what it's saying is that ICU beds comprise 5 to 10% of the total beds, but critical care services represent 25 to 38% of the cost, right? So on the total discharges side, or the number of patients in those beds, in the discharges with an ICU stay, which is the green, but you can see hospital costs. So a small amount of the patients are taking a huge amount of the money, or using a huge amount of the resources. Expenses are rising, everything that we do, the pharmacy in particular with the biologics. I don't know if you've ever seen those numbers, but it is just, they're astronomical, right? So all of that comes back to what's the total charge, what's the total cost for the patient, and what the hospital has to absorb. All right, we talked about that. So most ICUs, as we said, are run by non-intensivists who aren't there the bulk of the day. They're run by pulmonologists who have outpatient practices. They're run by hospitalists. They're run by whoever might be in that small community hospital. So one of the things that leads to is excessive consults and not very good communication among services. You know, you wonder why, or maybe you don't really care, but usually when I start the service, I give my little talk about we're not going to consult everyone who's out there. And again, that comes from a practice of being in a small hospital, also being responsible for costs. Because if you add neurology and nephrology and, I don't know, pick whatever, cardiology to your consult list, what are you going to end up with? You're going to end up with a CT, an MRI, or an EEG. You're going to end up with, maybe nephrology wasn't a good example, some lab tests. You're going to end up with an echo and whatever else, right? Now, I'm not saying that those aren't appropriate things, but we don't always need them, right? You don't always need another CAT scan or another MRI. And depending upon the state that you practice in, you have to understand the difference in how patients are billed. So New Jersey is a DRG state. So you come in with respiratory failure, right? You get paid X. There's a dollar amount that's attached to that diagnosis. Diagnostic related groups, right? So that's what you get. Now, you do have the ability to alter that a little bit based upon some of the other factors in the hospital and this, that, the next thing, but that's largely how you get billed. In Maryland, for instance, the billing system is per admission. So if you come in for 1 day to deliver your baby, or you're there for 60 days because of your respiratory failure, mechanical ventilation, it is the same dollar amount. Each hospital is assigned, like I was in a small community hospital. I got less money than Hopkins did. Hopkins got more, right? But it's still the same system. You get paid per admission, so you better make that work well for you, really. What's the best admission? Best admission is the person who comes in and dies an hour later, right? Because then you collect the amount of money, but you haven't had all of the expenses. Other states are more of a, you submit a bill kind of state. But everybody's trying to keep the costs down, right? So just understand in whatever state you practice or whatever you do, if you're the director or you're in the ICU, someone's gonna look at your costs and how much are you spending. So again, depending upon where you work, that's gonna be a bigger issue or not, depending upon what the revenue is. So that gets back to what I told you to begin with. That's why you want to make yourself important to the hospital, because you're not necessarily making money for the hospital. Okay. In situations where you're out in the community, or even here, quite frankly, you want to be sure that the hospital pays the ICU director, right? Because that person is responsible for leading the team and should be an advocate for the staff and the patients. So that should be a position that reports to the hospital. This was the most recent I could find on Leapfrog, and it's from 2015. Do you know what Leapfrog is? So Leapfrog is a group of companies who buy health insurance, like the Fords and the GMs and the IBMs and the big conglomerate of companies who actually pay for healthcare, right? So those companies got together in Leapfrog and said, if we're buying, we want to regulate what we buy. We want to make sure that what we're buying is the right thing. So this Leapfrog group got together and decided what standards did they want for the ICU. And that's where you hear things like an intensivist at least 8 hours a day, somebody who's at least FCCS trained, they have a list of things. Now, they have other things they want to know about too. They want to know about surgical outcomes. There's a number of different things on their leapfrog group. But leapfrog standards for the ICU are an intensivist at least 8 hours a day with the ability to call someone in within, I forget what they are now, I think it's an hour, have other people who are, that sort of thing. So having said that, in 2015, only 47% of hospitals were in compliance with leapfrog, okay? So I don't have 2020 numbers, couldn't find them anywhere. And this is just a map saying basically the same thing. You can see that in the middle of the country, there are less. On the coast, a bit more. So, okay. Economic benefit of being an intensivist. So you have to, again, be the gatekeeper for utilization and for the care that's happening in the unit. It's the turnover. It's being able to, at Cooper, it's being able to get those transfers in from outside hospitals, right? We need to keep the beds moving so that our patients move out to the next level and we get the next person in from wherever they're coming. The whole round-the-clock care, which we have here 24/7, again, allows that to happen in a more efficient manner. Things like, we talked a little bit already about consults, conflicting orders. Remember that just because a consultant says you should order XYZ doesn't mean you have to order it, right? You can simply say, I don't think we need to get another MRI because we had one yesterday, or whatever, right? It doesn't mean that you must do those things. You're asking for an opinion. Now, you may have to make a good decision about whether or not you don't want to follow their recommendation, which is sometimes why I think it's better not to ask, right? So think through, what are you asking that other person to do, okay? And are you going to take their advice? Using benchmarks, so there's tons of data available these days. In the ICU, we're looking at things like all of the sepsis bundle, we're looking at infection rates. You guys have heard all of these things. Why are they so important? Well, because they do drive quality, but they're also reportable, right? And so when your ICU comes up in the headlines as having the lowest scores on the sepsis bundle, even if it doesn't look good, the optics are not good for the institution or for you. So it's important to know what data you can get. If you're in a small hospital in every hospital, there's going to be somebody who does this, right? Who collects this data. They have to, because they all have to report it. So partnering with that person to say, here's the info I need in the ICU. Because you may not have a lot of resources to get that info. So there is pretty compelling evidence that intensivists actually can reduce or improve outcomes. So we talked a little bit about this, but these are some of the things that actually do have data associated with it. But do also understand that 24/7 staffing does not pay for itself. So I was in this ICU, I told you when I first started, there was one ICU, we had 6 beds, and I had 24/7 attending intensivists, okay? So add it up, like it just doesn't necessarily pay for itself. So hospitals have to buy into wanting 24/7 intensivists. They have to be willing to pay, right? And for the 24/7 stuff for us, it was about 500,000 to $1 million, somewhere in that range. That at that time, that the hospital had to kick in, right? But the issue is that if you're doing those other things I told you about being the gatekeeper, cutting down some of your other expenses, watching your drugs, on the backside, right, they're saving money. So that's why you have to watch that so carefully. When I did it, I was not working for the hospital. I was actually employed by what started out as an ED staffing company that then morphed into critical care and changed its name, I think 4 times during the time I worked for them. But nonetheless, so that made things a little more difficult. If you don't work for the hospital and you're a contracted service, that does set up some animosity between you and the rest of the medical staff. Just, if that's the situation you're in, you have to realize it, you have to address it, but you can still win in the end, This is staff receptivity. You're going to start a new service, right? So you want to really gauge the receptiveness of your nurses, the medical staff to having intensivists. Remember that whoever was there before you is going to lose money because you're there. Okay, Jason, what do you think? Am I? This is bizarre. So anyway, those other people are going to lose money because you, in fact, are now taking those patients, okay? So you gotta figure out how you're gonna work it out with them, so to speak. One of the ways that I did it, for instance, you know, when I first started, it was July 1st, and I was doing 24 hours. And so there was a consult to a surgeon to put a central line in, because remember, like, they don't know who I am. So I'm sitting there, the surgeon like walks past the desk, walks into the room, gets the kit, he's gonna put the line in. And the INR, I don't remember the numbers, but like the INR was like, you know.
12.
Yeah.
Yeah.
Yeah. And so I went over and I said, hi, my name's Tony, I know I'm one of the new intensivists here. You know, I know that you probably didn't have an opportunity to see it yet, but did you know the INR was 12? And, you know, he obviously didn't put in the subclavian at that particular moment. But you know, you use some of those opportunities to not make someone look embarrassed or, you know, stupid, but to say, I'm here to help you, right? You have to be kind of ingratiating, so to speak, to get people to finally trust you. There was one woman who was a private practitioner, an internist, who would never have us see her patients, ever. So that's how we started, and we ended up with her bringing me cakes for Christmas, and you know, so you can get there, just don't assume it's automatic, right? Because you're new to their world. You have to figure out what you're ultimately going to do in terms of who's going to work with you. If you're the one making decisions, are you going to hire more intensivists, which are more money? Are you going to hire extenders? Are you going to work with nurse practitioners? Are you going to incorporate hospitalists into your night coverage? Are you going to use an EICU? I mean, those are different things to think about in terms of your staffing model, because those things cost different amounts of money, right? So those are some of the things you're going to have to work with your administration on. When we started in this small ICU, it was a totally open ICU, and consult to critical care was totally optional. You could consult or not, right? We ended up, when I left, with all patients on our service, and so there was obviously no options. I mean, you were admitted to our service. And I used kind of a tense situation, if you will, to move that ball in my direction. I was literally sitting at a nursing desk, and somebody came up and like floated this EKG down in front of me, and it was an EKG with it was literally sine waves. And I'm like, what's this? Oh, you know, it's bed so-and-so, Dr. whatever his name was, just sent this person in from the office. Didn't call me, didn't talk to me, didn't tell me the K was 9, didn't anything, right? And so, what kind of care is that? So I was able to use that situation to, again, get everybody on board to, this can't be like this, okay? Again, depending upon the situation, you want to define the intensivist role, know the rules, and you know, and influence them in your direction as much as you can. Communication, you guys do a ton of that here. We talked about tracking performance. I would say that if you end up being the director, you really want to have meetings with your group. I mean, you guys get on some of the calls that we have. Talk about how the service is working together, how you're performing, so that you look like a group, not 6 individuals who are going to swing the care of the patient every day, right? And as the director, you should give other people feedback, right? And it's best to have that kind of open conversation. So I'm going to switch over now, because I'm trying to get this all in before it ends, to talk a little bit about rules to live by. I don't know, Jason, I actually didn't ask you. You had a similar experience? Do you wanna-
it was almost, you just like relived the whole first 2 years of my life. No, I mean, I started in a private hospital. It was a brand new intensivist group, and it was very, very tense in the first year. I mean, you know, we morphed the medical ICU and the surgical ICU into one practice. We closed the ICU. You know, both private internists and, believe it or not, surgeons were the surgeons were probably the most vocal about not having intensivists, because they would round on the patients every single day, and many of them would bill critical care time, which you would never expect a surgeon to care about post-op notes and billing critical care time in the ICU, but they all billed it and they all got paid for it. So that was a big deal. You know, the other part of it was, you know, the idea of safety and quality doesn't take a lot in a hospital to project that we have both safety and quality. When we talk about leapfrog, I think it required like 4 hours of intensivist coverage when I was there. May have changed, but that was all that the original group had to cover until I think it went to 8 hours, which was part of the reason to bring us in. You know, when you brought intensivists in, at first, the hospital administration got super nervous because our numbers looked way worse, right? So like the mortality rate in the ICU all of a sudden went up. And everybody wondered, why is that? Well, we were handling all of our own palliative discussions. We had an inpatient hospice that was connected to the hospital, right? But we were leading most of the palliative discussions, and patients were then staying in the ICU to die as opposed to being transferred to inpatient hospice. It was a big deal. What else can I say? You know, I think, you know, one of the big deals was bringing new pieces of practice and then rolling them out too quickly. Point of care ultrasound was a huge deal when I first started. You know, it's become, you know, in 6 years, it's almost synonymous with intensive care medicine, but it was still relatively new and there was no formal training. So because I had a lot of experience, I did a bedside echo on a patient in the ICU, and a Hopkins cardiologist saw me do that and went directly to the president of the hospital and complained. But by the time I left, she would text me to go see patients of hers on the floor, take a quick peek, and let me know and let her know what I thought, because she was worried about them, right? So, I mean, that's when it, you know, as your practice evolves over time, and you get a couple of wins under your belt and you gain people's trust, but you really just have to try not to roll in as the new guy and try to change everything and act like you came from some super center, because many of the docs who work in some of these small hospitals were all extremely well trained and they're extremely smart, and many, you know, we don't give them enough credit. Many of them are very up to date with the literature. Just because they're in a small place does not mean they have a small mind. So, you know, you can come in and put your foot in your mouth right away and find yourself in like a world of hurt. But over time, they adopt. Because I remember when we first built the model, the hospital expected to lose between $200,000 and $500,000 per year in the first 2 years. And that was a big deal for a hospital, to build the service and expect to lose money because it was so expensive. And they did.
And that's why you have to provide value in a different way, right? So that they can justify the whole thing.
Absolutely.
So that was a great lead into my rules to live by. So number one is just what I said. Don't start every sentence with the way we did it at Cooper is, right? Because that's not really going to ingratiate you into their world, right? That's my whole point here. You're not there to save the day. They were there a whole lot longer than you. Now, you may go there and find many things that you think are not correct. And I will tell you that in the 1990s, I went into this small hospital. I would tell you, I thought it was like medicine at its finest in the 60s. I mean, I was just appalled. I was like, why did I come here? Why am I doing this? I've taken a step back. One of the orthopedic surgeons said to me, I hear where you come from. They give Coumadin after hip replacements. And I was like, thinking to myself, like planet Earth, like don't you anticoagulate after you do major joint replacements for some period, you know what I mean? But you don't say that, right? They've been doing it without you. So I would suggest to you that you spend some time learning how they do it before you try to tell them you're the best thing since sliced bread, right? Understand referral patterns. So here, what's the referral choice we have? CADV versus university, right? Like we don't have any other choices. It is who it is. But out there, you know, it might be Dr. Smith versus Dr. Jones, and if you're seeing a patient and you need, I'm gonna make up your cardiology and you just consult Smith, but Jones is the attending's preference, like it's a war. So be careful on that. If you're the one scheduling, remember it's not an ED schedule for the ICU. You need continuity. You need to build rapport with patients and families, having regular meetings with the group. Don't forget to touch base with all of the other people, the nurse manager, respiratory care director. Try your best, and I'm horrible at this, but try your best to learn people's names, connect with them, right? Because it's those relationships. They're going to support you. When you set up meetings, you know, this is another one of my pet peeves, don't have meetings for the sake of meetings. If you need a meeting, have it, otherwise don't waste people's time. Pick your battles. So I was maybe in my first or second year running this ICU, and I had a great boss who said to me, you know, Linda Wedra, the CEO, Linda Wedra doesn't really like you. I was devastated. I'm like, I've done all these really great things. Like, what do you mean she doesn't like me? And he, you know, told me that I couldn't fight every battle. Like I told you, I was appalled at many of the practices there, so I was going to fix them. And you have to be careful on that, right? It takes time for them to trust you so you can fix them. Somebody once said to me that giving their patient's care to me was like entrusting their child to a babysitter. Like that was, you know, they care about these patients, right? They've been seeing them in the office, they've been with these people, and who the hell am I? I've come in and now I'm going to direct their care. And that really made me think about how much the docs really care about their patients and the issue of handing them over to an intensivist, right? So anyway, the advice that was given to me was pick your battles. Don't make everything a huge issue. If they want to give one thing that isn't going to hurt the patient, just let it be, right? And also be careful who you're going to fight with.
It's really interesting you bring that up. I had one. There was a few concierge specialists at this hospital too, and one of them was a bridesmaid in the patient's wedding. They didn't know each other before the doctor-patient relationship. You know what I mean? So like it runs deep, right, to the point where you would, you know, make your doctor one of your bridesmaids.
Having said that, though, I think you can use the "I'm new here" to your advantages sometimes, right? Sometimes when you really think you need to move something forward, you know, you can use the "oh, geez, I didn't know that. I'm so sorry. You know, how can I help?"
That one's powerful.
Yeah.
I did that for about a year.
Yeah.
Yeah.
Sometimes you can even stretch it.
Yeah, almost at the point where I left.
Yeah.
Like, I'm just still new here.
Yeah. Look for opportunities to shine, like I told you about the coags and such. Keep the primary attending informed if you're not, because again, it's their patient, right? We talked about managing the unit, meeting with referring docs, yearly budget requests, because you're going to be part of that. You're going to need to tell the ICU director what things you need. So I told you I bought a whole fleet of ventilators outside of a cycle. You know, that doesn't happen very often. So you need to plan ahead. If you need to buy that new ultrasound machine or whatever, make sure that you keep that in mind. You want to follow through on things that you say you're going to do, and don't raise your voice. I found that when you get quieter, actually it keeps the tone down in the room when there's an emergency. People aren't going, you know, as crazy as they normally do, and they'll stop to try to listen to you because your voice went down and not up. So just something to think about. Getting involved in nursing issues. So there's the doctor line and there's the nursing line, right? Now granted, you work together, and I was in the midst of, for instance, a nursing strike at one point in time, and actually there and here. And you have to be very careful because you are not a nurse. You are not in their line of authority. You are not part of them, right? So all I'm saying is just be careful when you pick up the crusade with the nurse, because it's now potentially against the hospital. Just think it through. Think through how you want that to be seen, right? So it doesn't mean, that you can't make a point. I mean, I was asked, I don't know, 5 years or so ago here, there was talk of a nursing strike. They were down to like the last few days. And one of the ICU nurses said to me, Dr. Spevetz, are you gonna cross the picket line? And I said, of course I am. I have patients, right? And they stopped. I mean, they actually stopped in their tracks and said, could you come in the back door? Okay, if that will make you happy for me not to march in the front door, I can do that. But in the end, will I abandon the patients? No, I will not. So you can make your point, but again, be careful getting sucked into things. That got me in trouble more than once. You can still advocate for your unit. Make sure that when you do protocols. So one of the things that I did there, and actually one of the reasons I came back to Cooper, was to really get the ICU protocols up and running. And I spent all sorts of time and energy like researching things and putting them together and showing them to a few people and putting them out, and then they just fell flat because I didn't get all the stakeholders really involved. I didn't get everyone else to really buy in. So my advice to you there, when you're doing protocols and such, you have got to think through everyone who could possibly be involved. And then you can rah-rah them and get them involved and show it to them, and it's probably exactly what you were going to do in the first place, but nonetheless now they own it. So that was one of the things that I didn't do well initially. Don't change too many things at once. If you're in a small hospital that doesn't have residents or fellows, I would suggest to you that you should still have formal rounds, just like we do them every day. At that point in time, we did them at 2 o'clock in the afternoon because I felt like I needed to see the patients first. So I would round, so it was just me, right, no fellows, no residents, so it took me, I didn't have to see everybody. So I would round and then we would go bed to bed to bed. I will tell you that made a huge difference in care. The nurses presented the patients, everyone chimed in, and we absolutely elevated the care in that ICU and frankly in that institution. Get everybody involved. Patient safety, meet your administrators. Again, if you don't have residents and fellows, you still have a constituency to be part of their education, and that's your nurses, your respiratory therapists. If you teach them, it will make your life oh so much easier, right? Because they know what you want, they know what the right thing. As a director, Larry probably can speak to this as a chief resident. There's always two sides to a story, and when people come to you angry about something, upset about something, initially I felt like I had to give someone an answer. There's two sides to a story, there's probably 3 or 4 sides to the story, so sometimes you just need to listen and say, let me look into that, or let me get back to you, right? Be careful about jumping into what seems to be an incredibly egregious story that you've only heard a part of. Because again, as the doctor, they're gonna come to you with those stories. Be a leader, and again, this is the don't think you always have to act. Talking with people directly. Now this one's a little tricky, right? Let's say a nurse does something bad, whatever that is, wrong. On one hand, it's nice to go to that person and say, this is what I observed, but you do have to be a little careful there because, as I'm saying, they don't report to you, right? So if there's something that you see, you should try to directly go to that person before you go to their supervisor and say, this isn't the right thing. We already talked about a uniform approach. Hospital committees, again, get involved in the institution. And then I think this is my last slide. When you leave here, figure out what you want to do. Do you want to? When I was in Maryland, I as I told you, the 6-bed hospital then grew to 2 hospitals and more ICU beds and whatever. But, you know, I was still in a small situation. And there are some very many people in private practice who are quite bright. But there are also others who have let their skill set kind of, you know, fall to the mean, if you will. And so for me personally, I missed the part where I could have an intelligent discussion in the course of the day. You know, why is that patient in heart failure? Why is the CO2 up? Why? What are you thinking, right? When I'd say something like, you know, talking about the heart failure, I would get the answer, give Lasix. And I don't mean to be negative. These people cared a lot about their patients. But really having a higher level discussion wasn't what they were used to participating in. And I felt a void there. So I would drive from Havre de Grace, which is north of Baltimore, to the NIH, which is on a traffic day, a couple of hours, to participate in the DC Critical Care Society, because they would have meetings every month or so, and they would present cases and blah, blah, blah. So I would drive down there, with 4 hours at least of driving, right, because it started at 6 o'clock at night. But the reason I did that was, one, for me, right, but also because I felt like I need to stay involved so I can keep this unit and these people up to date, right? So, so you need to decide what you're going to do when you leave here. If you're in a small hospital where you don't have a lot of ability for academic stimulation, what are you going to do? Are you going to choose to get involved in a group like SCCM or ACCP or ACP or CHEST or, you know, whatever it is, right? But find something that makes you happy. Emergency medicine, you know, is that the group that you want? Because you have an emergency medicine group on the SCCM side as well as on the ED side. You know, what group resonates with you? But find a group, right? And start to participate in that. Go on job interviews. You know, for a period of time in my life when I was in Florida and I didn't like it, and then I went to Maryland and I was like, I gotta get out of this little place, right? I went on a lot of job interviews. I made so many friends throughout those years going, and I didn't do it if I had no intention of going there. I mean, I actually did have intention of going to these places. But I just developed so many relationships because of it. So don't waste someone's money. But on the other hand, it's not a bad idea to see what's happening. Be honest. So, you know, I didn't have many, actually, that's the wrong word to use. I had few people who actually left my group in Maryland. The group really stayed together. The few people who left, I had a guy who went to Hopkins. And he still continued to moonlight with me. But my point is, you know, if you're honest with someone and you simply say, you know, Jason, I've been here a couple of years, I've enjoyed it, but I really think I need to go to blah blah because it's just such a better opportunity for me. How can you fault that? I can't fault that, right? I mean, each of you have to make the right decisions in your life for you. So if you're if you're honest, if you tell people what you're doing, if you don't screw the person when you leave, then that's just part of life. But when you're not honest, you know, when you don't give appropriate notice, that's when there's problems. I had a guy who took my job and then didn't communicate with me. It was May. It was June. I was starting to put him on a June schedule or July schedule. It was June. I was putting him on a July schedule, and he called the company, who then called me to say, "Oh, by the way, I'm not starting." Well, let me just say he didn't get another job in Baltimore because that pissed me off, right? And people would come to me and ask me, like, you know, did you know this guy? Yeah, and that's what he did. So I'm just saying that, you know, critical care is a small world. Just don't do things that are unprofessional. Be upfront. Had he come to me and said, my mom's dying and I can't come, I have to go to, right? That's a whole different story. But to just simply not show up and not address it is not it's not gonna be a
Yeah,
deal.
Steve just asked a question, is 3 months notice reasonable? I think in most of your contracts, 90 days is gonna be required for you to leave a position, so think about that ahead of time. It takes every bit of 90 days to fill a spot for an intensivist, if not more. I think most of us, and, I interviewed.
It's 6 months here.
Yeah, it's 6 months here. I interview people constantly, because of turnover for intensivists, and, the staffing agencies are extremely expensive, and you'll feel the pressure from administration to find somebody. That's why when you said is be honest on your job interviews too. If it's not for you, don't make people think that you're gonna sign. There's nothing more frustrating than, pushing other offers, or putting them on hold, waiting for somebody to commit only to find out that they signed a contract a month before with some other hospital system and are just trying to use you as a negotiation. Those people will never work in Maryland again. And trust me, like there's, in states and hospital systems, they're not as big as they seem. Everyone talks to each other. And to this day, I get, I know a guy who trained in so-and-so, and they knew this guy, you know that guy. If I gave them the absolutely don't go after that person, there's not a shot that that person would even get a job interview, because that's how much they trust everyone.
Yeah.
So.
It's a very small world. I mean, I just really want to emphasize that to you. So, as Jason said, treat people fairly, honestly. If you're going to interview, I was in Pittsburgh interviewing for jobs, and I had 2 interviews back to back. The first place asked me, "What are you doing tonight?" I mean, it was just right? And I said, "Well, actually, I'm having dinner with the people from," I forget which one, UPMC or whatever. That night, guess who was in the same restaurant together simply by chance? So had I made up some story, right? The guy that I interviewed with that day walked into the restaurant where I was sitting with the UPMC people. So I would have looked like a jerk, right? So people know you're interviewing, people know that that's the way it goes, right? So like you said, just be honest. If you're weighing 2 offers and you get offered one and you don't want to commit, and then I think you say, I'm struggling between these 2 offers. Don't say, oh yeah, I'm coming, gonna be there.
Yeah, and be careful with correspondence. I had one job that I was very close to taking at Jersey Shore, and then the one in Maryland. Both directors, chairs of medicine. One's name was Friedman, and one's name was Freelander.
Oh no!
And the autocorrect in my Gmail sent the email to the wrong person. I'll never forget that phone call, because that's when I decided to take the job with the other guy, and I sent him the email that I was going to take the job to the wrong guy. Before, and I talked about the job in Maryland, and he called me up, and this was I thought he was the nicest guy in the world. I have never been cursed out like that in my life.
Oh my gosh.
Because they were having a really hard time locking down an intensivist, and he thought that I was like a shoo-in to take the job, and I didn't take the job. I was struggling with both those jobs, but those are really important. I mean, I think, 2 pieces of advice that I always thought were really important were never let them see you lose your cool, because you can never get that back.
Yeah.
Like when you just fly off the handle, in the middle of the unit, no matter how stressed out you are, whether you're neck deep in COVID, if you lose your mind in front of people, you'll never get that respect back. And then, the 3 most important things are people, and people. If you hire the wrong person, it can totally be toxic and ruin your intensivist group. And that's hard because people seem great on paper, but, a lot of the people who are recurrent hires, you have to be careful of, because they're usually that way for a reason. They may be great doctors, but they can be very difficult to work with. Because I think that's one of the most important things. You guys spend 2 years building your clinical approach, right, and how you want to deliver care, and then you get to a job and you find out it's not that easy, right? Just because you're right doesn't mean you're right? Just because you can say what should happen, if you say it the wrong way or you advocate for a patient in the wrong fashion, you can burn all the bridges around you, and then people won't want to help you. Right, they won't want to work with you. You you can find yourself. So, you know, building the platform for you to deliver your care is part of the reason why we want to make this a recurrent lecture series, because in order for you to deliver care, you have to have a platform to do that, and that comes with understanding hospital administration, you know, figuring out how you're going to sort of, you know, I don't know, advertise yourself within your hospital when you get there so that people come to you to help deliver care and don't sort of run away from you or do whatever they can to kind of, you know, kill an idea that you may have, which if you make enemies will happen right away. You know, and everything costs money. You know, so just because you know, you think things are necessary to deliver care, you may find somebody who's, you know, especially if they're going to build an intensivist program for you, are quick to sort of help you get the things that you need, but you have to be sure that you know, that you can follow through on promises. I mean, point of care ultrasound is a big one, you know, when you sort of advocate for resources. You have to understand that, you know, behind the mahogany door, there's a lot of things that happen that have nothing to do with how good you are at, you know, at delivering care. You know, when, like for our group, the first thing, you know, you'd go to and sit, you know, everyone was super nice to you, they loved you, but then you would sit around the round table and you would have to advocate for why your costs are more and your sepsis matrix are worse and your mortality is lower, and you find out real quick that these people mean business, right? Because they have a responsibility to keep the doors open. And you're not used to seeing that side of medicine at all. You know, it's just all about, you know, delivering care at the bedside. It's not about cost and, you know, and referral patterns and, yeah.
One of the most eye-opening things that I did was, we used to be part of this healthcare advisory group in Maryland, and they would do these different modules, and you would spend a couple days on something. And one of them was pharmacy, to really see how much the pharmacy eats up a hospital budget. And now, you know, that's like peanuts compared to what it is now with the biologics. And so, you know, that's one of the things that when your hospital administration says to you, you know, you need to do X, Y, Z with the meds that you're using, or you can't give these sorts of things. So there's all of those workings behind the scenes that we don't see, or we don't maybe you guys don't pay attention to on a day-to-day basis that are really so important when you actually go out there and try to run that unit or you know, be one of the faculty. All right.
Question?
I have a question.
Yeah.
Because I know we're kind of at least here, two major different camps. You know, they're going to be starting jobs, you know, in moments, and then we will eventually be, you know, really getting out there and looking. My question is sort of how, if it takes about 6 months that you're looking for, you know, a new position, trying to fill a new position, would you recommend we start, and how does that look like now? Because I was planning on kind of being very serious about it in the next, like, you know, I think about it being in like 4 months, 3 months, like something to be at least be aware of things. But I can't imagine anyone's budgets are like ready to tick off new intensivists.
Yeah,
Like
well, right now, you guys are in a very in-demand specialty. I don't know. You know, I remember I sat down with my program director. I always remember, and I sat across from Steve Treziak, and I asked him, so, you know, for advice on how to find a job, and they both looked at me and said, I've never had to look for a job before.
Yeah, I know.
Okay. So I don't know what the
I've got a
best.
lot of
I don't know what the,
fall.
yeah. Yeah, I don't know what the best advice was, but after having that meeting, I started very early.
Okay.
So I created a brand new email account,
Yeah.
and so probably, you know, after we rolled into August, September, I created a brand new email account, and I subscribed to all of the staffing for intensivist email. So there's like the critical care staffing and like the physician staffing websites that you just click Intensivist, and any new job that comes across gets kicked your way. You can subscribe through SCCM, New England Journal, JAMA specifically for Intensivist, and all of those emails start getting kicked your way. And then, you know, I would just start to sort of rank them to what was available, the timing, and then I would start, you know, I started sending out resumes early. I went on a lot of job interviews, a lot.
So,
August, September.
I started applying to jobs in August.
Yeah.
The issue that you're gonna run into is if places like you and send you a letter of offer,
Yeah.
that you're gonna have to tell them, you have to be honest with them about your timeline. So I had an offer from guys here in Wilkes-Barre in like October, November, and I told them that I wasn't gonna be deciding until March at the earliest, and that they had to be okay with that. And if they weren't, then it was gonna be a no-go, because I wasn't gonna sign with them early
Yeah.
while other opportunities weren't even posted yet. It
Right.
still kind of like didn't work, because like I wish I'd known about that New Mexico job, because like I might have
And
actually
things
thought
pop
about
up,
that,
and
because
that's why, like, you know, that.
you wanna leave it late.
Yeah,
Right.
that pathway, I have to admit, is probably, you know, it's what most people are going to use, but, you know, knowing people, because the jobs that aren't advertised are the jobs that everybody wants, you know what I mean? So that's where, you know, I constantly talk to people, just like you did. I mean, my first job was through a friend of Dr. Spevetz. That job wasn't advertised. And that's why I remember getting a call from the ICU director who was working with Marie, and he was like, "I've never even heard of you, man. Your resume just came across my desk, and I was first to call you. So tell me your story." You know what I mean? It's like they told me I had to call you.
The other
So
thing, too,
yeah.
if there's a location you really like,
Yeah.
you can always just contact them directly and see if there's something off the books.
I went on a couple really interesting ones. Some of the you know, some of the academic positions used you for grand rounds, which I felt
I've heard
very,
this.
because I felt very used during those jobs.
That was horseshit.
That was
Yeah.
like multiple you
Yeah.
had, right?
But I got paid to go interview, because
Yeah,
they
you
I
did
did like
that.
$400
Oh, yeah.
to go down, and they pay you like $400 to go give grand rounds, and then they would interview you in the afternoon, and so it just sort of felt like the way that
So that's
that
why,
ICU
okay.
director used the job to fill his grand round schedule for an entire,
But that's a thing.
quarter.
Apparently.
Yeah,
What
so.
was your transition like going from community back to academia?
It was, you know, again, I think it comes down to, you have to find out what the group's like mantra or mission statement is, right? So for the group that I signed with, everyone, you know, was relatively, some of them have been around for a while, but most of the intensivist group were all relatively fresh, all out of large tertiary academic centers, and all had the idea of what we believe in a high intensity intensivist setting, but bringing it to the community. And that's what I found very interesting, because again, you know, 70% of our family members are going to be cared for in a community ICU, right? So the idea of trying to bring, you know, a high intensity intensivist model to the community and to do it well is still something that people struggle to this day to do and sustain. You know what I mean?
And you
Because
guys also talked about a uniform approach. How do you balance it between, you know, like having a cookie cutter medicine, right? Versus like having a group of bright, smart,
Yeah.
creative individuals. How do you balance between having a uniform approach and
Yeah, so what we did was say that the day person set the plan. And so unless something major happened, you went with the day person's plan. So if the day person was giving fluids, unless something major happened, you didn't give Lasix. So that's kind of how we did it, because there were some of those swings, and I can tell you that, you know, you probably see it more than I do, but people still complain to me here that, you know, the day and the night are not the same. And that's something that really we shouldn't do, right? Because it doesn't really engage, what's the word I want, make other people trust us as much when there's swings in care. But to your question about going from private practice to academics, right? That's not usually the way it goes. I had been trying to get back into academics like for much of those 11 years, right? I told you I went on a lot of job interviews. You know, one thing after another, but there was a job, I always worked at Washington Hospital Center, then the Gulf War happened, and they lost funding, and like things happened along the way, right? And so I ended up staying. I actually wasn't looking for this job. I was on vacation with my niece. I took my niece and nephew to Europe for a graduation present. And I got back, and Joe Perillo was here at the time. And there were all of these messages from, I swear, half the people at Cooper, like, you have to call Joe Perillo. Because he was looking for someone who could do operations. And so that's what I came back to do, the operations of the ICU, because I had built this service, I had run these units. At the time I left, I was running 2 ICUs. And so that got me back into, you know, this kind of setting, which is where I had been trying to get to all along. So sometimes things just fall in your lap, and that one fell in my lap. You know, other times it's knowing people, it's opportunities, it's other things that you've done. Through the SCCM, you know, I've had a number of leadership positions there. But honestly, it's given me the opportunity to know so many people and to, you know, to send people there who are looking for jobs. I mean, you know, I can't promise I can get you a job, but if you tell me where you're going and I have any contacts, I can certainly talk to people. So that has helped some of our graduates, you know, since they've left here.
Yeah, and I think that, you know, the practice pattern-wise, even if you went to work in a small center for a few years, you're still going to be the most up-to-date person out there. So, you know, that, I don't know that would keep you out of academics at all. I think, you know, it's comfort level. Like, I was very comfortable in Maryland. I had no plans to come back at all. And then I got a call from Steve, like one day when I was like walking, and I was like, okay. And then, you know, I told him I'd come up and interview, but I still didn't think I would leave, just because like I didn't, you know, I had such a connection with the people that I worked with that I didn't think I could leave them, and then I left them. So, you know, opportunities pop up, but you need staying connected, and that's where like some of this, the discussion about how to properly build that stage and you know, and stay connected and to network is probably more important than anything else, you know. And then on top of it, I thought if I was ever going to leave my job, it would be to go to one of the academic centers in Maryland. I was already probably going to take through the Baltimore SCCM chapter, which I was part of, and that's the SCCM chapter that Dr. Spevetz started. For about a year, nobody knew my name. I was Tony Spevetz's fellow.
Nice.
Yeah. But I never missed a meeting, and then eventually, you know, I got to get, you know, you sort of move tables like the Hopkins. Like the Hopkins and the Maryland guys kind of sit in the middle, and everybody else kind of hangs out in the periphery. And then, like as you like network, you start to make it to the table, right? And then you're sitting at the middle table having dinner with everyone, and then that's where conversations happen.
And that's 100%. You know, because I told you about driving down to the DC chapter. So we got tired of driving, right? Because the Baltimore people were going as well. So that's how we started this Baltimore chapter. And so the drivers of starting this chapter were Maryland, Hopkins, and Upper Chesapeake Health. So I'm just saying, like, I was at the table with the big boys starting this chapter, and we rotated it. So one month it'd be Hopkins, Maryland, and then Bel Air, you know. So if you can do it, is the point that I'm making. There's nothing special about what I did. You can do it if you want to do it.
You know, and sort of deciding what you want to do, I think is really important. I think everyone sort of is comfortable in academics because it's everything you've ever seen, but don't close the door on private medicine or community medicine up front, because there's a real opportunity for you to probably do the things that you would not be able to do in a junior faculty position early. The responsibility that I was gifted, I guess you could say, in my first 2 years is something that I would never, and I grew up like I was not nearly the same person that when I started that job. And had I not been given all of these opportunities and then been forced to sort of troubleshoot my way through everything I didn't
I'm just finishing
understand, I
a
probably
conference.
never would have
May I
grown
call you
up
back?
as quickly. So there's a lot of opportunity out there, and in a smaller setting, you can make change very quickly, and get people on the right track.
Much faster.
Yeah.
Well, thanks, guys.
Thank
Thank you.
Yeah.